Continuing with the applied of the optic tracts. So we are doing the neuroanatomy part of the anatomy. In the neuroanatomy, after doing the brain, we are doing the spinal cord, the part of the central nervous system. And in the first week of coming September, we will be having a test. The syllabus of the anatomy is all of the classes you have attended from the day 1 till 30 of the August. So it will include everything you have done. This paper will be midterm. It is about the middle of your ending of your first year. And the question paper will be like the university pattern that you will appear in the month of the February or March. So be prepared, 21 days are there. So I have seen in the YouTube that only a few have touched the spinal cord. I have started 10 days back. So don't miss it. It is included in your syllabus. Along with the anatomy, there will be also physio and bio test also, midterm. All together, within 1 week, you have to give the return of the 3 subjects. So be prepared for that also. So in the applied, we have done the how the optic nerve, optic tract, optic chiasma at the different levels. Other reflexes which are related to the eye, they are corneal reflex. As we know, eye is very sensitive. The cornea part is very sensitive part of the sclera. So anytime you are going on the bike, if any insect comes and it touches your cornea, it's a very painful procedure, number 1. Second, your eyelid closes it. Eyes reflexly close. So this is called the corneal reflex. No doubt the cornea is covered by a very thin sheet membrane, that is the conjunctiva, to protect it. Still there is a painful procedure. So that is called the corneal reflex. The nerve which is supplying the cornea and carries the general senses from cornea, that is the pain, temperature, pressure and touch. So whenever there is a hot summer, your eyes feel that today is very hot beside your skin. Same is the cold sensation, they are also present in the cornea. Pressure, if you press the eye, you feel it that somebody is pressing. So all the skin sensation, pain, temperature, pressure and touch is also same on the cornea. And which nerve carries the pain sensation? So pain sensation, they come out of the sclera. A nerve which is carrying pain sensation is branch of ophthalmic division. What is the dictionary meaning of ophthalmic means? Related to eye. So you have seen out of 12 cranial nerves, 5 are dedicated to the eye. Out of 12 pairs. So see the importance of the eye. So this nerve which is carrying the pain sensation from the cornea, what is the name of this nerve? Long ciliary nerve. Remember, long ciliary nerve. And this long ciliary nerve is the branch of which other nerve? Nasociliary. Both are sensory. Sensory means S for S. Picking the general sensation from the nasal branch, carries the general sensory, pain, temperature, pressure from skin covering your bridge of the nose. Nasociliary. What is the ciliary part is doing? Carrying the general senses from cornea of our eye. That's why its name is nasociliary. And ultimately this nerve will go to the pons, because pons is the area from where the thickest nerve arises. Trigeminal with ophthalmic, maxillary and mandibular branch. So mandibular branch you have already done with the muscles of mastication. We have finished. So as you are progressing to do the head and neck, you are seeing that you are also finishing the cranial nerves. With the face, what you have finished? Facial nerve, 7th. With the muscle mastication, you have finished mandibular nerve. With the eye, you are finishing ophthalmic and maxillary divisions. So I have already told you what is head neck? Only the tracing of the 12 pairs of the cranial nerves. So this is the how ophthalmic division reaches the ophthalmic division of the trigeminal and reaches the pons to the brain. And what is the afferent impulses? Afferent impulses, they are from the cornea, from cornea to the nasociliary nerve to the ophthalmic division. And ophthalmic division goes to the pons, the part of the brain stem. So how the painful procedure reaches the brain. When something reaches the brain, we know it. So that is the afferent pathways. And this cornea is very sensitive and it is used for diagnosis the status of the patient. For example, if an unconscious patient came to the casualty, the doctor who is attending patient is unconscious. We don't know what is the reason of the unconsciousness, maybe diabetic or head injury or roadside accident, we don't know. So simple test, what we do we open the eye of the patient and we touch the cornea of the unconscious patient with the help of a cotton of earbud or cotton wool. What we see? There is a blinking of the eye. The unconscious patient is moving the eyes. It means his or her nasociliary nerve is okay. His ophthalmic division is okay. His trigeminal nerve is okay. His pons is okay. It means brain is okay. Without CT scan, a simple pupillary corneal test will declare that still there is a hope. You can say to the relatives that still brain is working. So that is the importance of what is pupillary reflex. If this nerve damages due to head injury or anything, there is no any response. Or if pons is damaged, brainstem injury is there, no response. Response 0. So that is the corneal. Second is pupillary reflex, or what is called light reflex. We know pupil is the part of the which layer of the eyeball? Choroid. Choroid is a vascular and muscular layer. It contains smooth muscles. Iris contains two types of the smooth muscles. One is circular and other is radial. So two types of the muscles we find in the eye. The circular, as named this, they are arranged in circular fashion. The radial are like the radial. So when this circular muscle they contract, what they bring about? Constriction of the pupil. Same is the tunica media in the wall of the artery and the vein. So when they contract, what they bring about? Vasoconstriction, as it happens during winter, thermoregulation by skin. These veins which are now visible very easily, in the winter they will disappear. Now they are vasodilated, so that heat should be lost, because blood is hot. When these veins they are filled with the blood, heat is lost directly from the skin. So this is the circular muscles, and they are smooth. They are not. They are involuntary. We can't control them. Who is controlling? Another system. What is that system? Autonomic. Always remember, circular muscles they are supplied by parasympathetic fibers, which bring about the constriction of the pupil, which is also called sphincter pupillae. Sphincter means again constriction. They are also called sphincter pupillae. They are always supplied by parasympathetic. Underline it. You'll forget. And this thing is, if you forget, you get 0. Then the radial muscles. So when the radial muscles they contract, what will they bring about? They will stretch the pupil, and pupil will be dilated. And who is supplying them? Opposite the parasympathetic is sympathetic. So sympathetic fibers, they always supply the radial muscles of the iris to bring about dilatation of pupil during evening and night. So sympathetic nerves they stimulate in the evening, and parasympathetic they stimulate during daytime. Bright sunlight, our pupils become small, so that they can't, only small amounts should reach the light, should enter into the lens, and it should not damage our retina. So again, this is like the thermoregulation of the skin, vasoconstriction and vasodilatation of blood vessels. Same is the pupil. So pupil is reacting to the light to save the retina, and we are well in to see during the night as well as the daytime. So that is called the, and another smooth muscle they are present, they are called ciliary muscle. And where the ciliary muscle are present? Ciliary body of the, again, choroid. And what is suspended from the ciliary body? Biconvex lens. Biconvex lens. So what happens? So innermost layer is the retina. Rods and cones is the gray matter, and the white matter of the whole of the retina leave the eyeball and form the second cranial nerve, which is called optic nerve. And optic nerve contains about 10,000 axons if you count them, and they are all coming from rods and cones of the big screen of the eye or the human, that is the retina. The center part of the retina where the image is formed is called macula. This is the peripheral part. So here is also image is formed. So binocular vision, retina is present. So what is the afferent of the pupillary reflex? So the light enters, passing through cornea, iris, touches the lens. From lens, image is formed here, inverted. And this conveyed to the optic nerve. And from the lens to the optic nerve to optic chiasma to the optic tract goes to the lateral geniculate body. And from lateral geniculate body, it comes to the internal capsule. Which part? Retrolentiform part of the internal capsule, which form the optic radiations. And optic radiation reaches the macula of the occipital lobe. Brodmann's number 17. When it reaches here, then we can see. So when you are in the examination, question is asked about the applied. If you are not having sufficient time, you can make this diagram. At least you get 1.5 marks. Otherwise, you have to write an essay. So try to write these are called line diagrams. So this is a pupillary reflex, and pupillary reflex is of two types. One is the direct, other is the indirect. So this is how the vision is there in this part. And another part is that when the light is entering, in response of the light, our pupil reacts as a constriction or dilatation. And what is that afferent impulse? Afferent impulse is same from the lens to the optic nerve, optic tract to the optic chiasma, then optic tract, and optic tract to the lateral geniculate body, and from lateral geniculate body it goes to the midbrain, and in the midbrain there is a tectum part, and there are corpora quadrigemina, superior colliculus and inferior. What is the function of the superior colliculus? S for sight. Remember, S for superior, S for sight, vision. And what is the function of the inferior colliculus? Ear. So superior is eye, inferior is ear. That is how to remember it. S for sight. So superior colliculus, it reaches from superior colliculus just near this superior colliculus, and anterior there lies the third cranial nerve. What is the name? Oculomotor. Oculo means eye, motor means movement. Again M for M, means this nerve will supply the muscles of the eyeball. Out of 6 extraocular, it supplies 4. So that is the. So this nerve stimulates these afferent impulses. They stimulate the oculomotor nerve, and this oculomotor nerve is also connected to a parasympathetic nucleus, Addinger Westphal nucleus. Addinger Westphal is a parasympathetic peripheral ganglion. It is a parasympathetic nucleus, as you have done in the parotid, inferior salivary nucleus. It is made for parotid gland. Similarly, Addinger Westphal nucleus lying in the midbrain at the level of oculomotor nerve nucleus is for eye. It is dedicated to eye. So this response will go to the Addinger Westphal nucleus. And from Addinger Westphal nucleus, what happens? Preganglionic parasympathetic. So it is a parasympathetic. So preganglionic parasympathetic fibers, they start from here, and they are made for smooth muscles in the eye. They have to reach the eye. So they will request the oculomotor nerve that we want to supply the circular muscles in the iris. I want to supply ciliaris muscle in the ciliary body. Please carry a few fibers. We are very few. You have to supply 4 skeletal muscles. So these fibers, they request the oculomotor nerve. Oculomotor nerve say, okay, don't worry, I will bring you. So oculomotor nerve now enters the superior orbital fissure and divide into 2 branches. You know already, because this diagram is very, very important. Draw and label the structure passing through superior orbital fissure. I think you have practiced it 50 to 100 times, because today is your substage also. So superior orbital fissure has got 2 parts, outside the ring and inside the ring. This is called the annulus of Zinn, and where it is present around the apex of bony orbit. So here we make the 4 yellow spots, only 4. You should know what is the 4. The upper and lower, they are the upper and the lower branch of oculomotor nerve. So it divides into 2. The lower branch further divided into 2 because it has to supply 2 muscles. Which 2 muscles? One is inferior rectus and another is inferior oblique. So oculomotor nerve is already going to supply these 2 muscles. It is already going to supply this muscle. So now this oculomotor nerve carries the preganglionic parasympathetic fibers already requested by them, so it has brought them, and it will accompany these preganglionic parasympathetic fibers will made to supply the ciliaris muscle and circular muscles of the iris. They accompanying the inferior branch, and out of inferior, these fibers they accompany the branch, inferior branch, which has to supply inferior oblique muscle. Again the choice is there. It doesn't go with this branch which supply the inferior rectus. No, you have to write whenever asked. They accompany the nerve which is supplying the inferior oblique muscle. There is a reason. Why? Because the branch which supply the inferior oblique muscle is having a suspension of a small pinhead sized ganglion that is called ciliary ganglion. It is only suspended to the branch supplying the inferior rectus of the oculomotor nerve. So these preganglionic fibers, they leave the oculomotor nerve supplying the inferior rectus, and now their destination is very near, so they enter the ganglion and relay here. The size of the ciliary is pinhead size. How many mm? 1 to 2. This is small. Only 1 to 2 mm size. See the importance of this small ganglion. Like the aortic ganglion is quite big. This is very small. See the importance. It carries the parasympathetic fibers responsible for our pupillary response. So they relay here, and what comes out of them? Postganglionic parasympathetic fibers, which comes out as the tortuous short ciliary nerves. And these short ciliary nerves, they pierce the sclera posteriorly around the optic nerve. Optic nerve is coming out, short ciliary nerves they are going in. They pierce the sclera, they pierce the choroid and reach the choroid. And from the choroid, these postganglionic parasympathetic fibers supply the ciliaris muscle. Then they reach the iris to supply the circular muscle. So this is how the parasympathetic fibers ultimately reach to supply the smooth muscles inside the eye. So that chart you should know how to make it. So now the circular muscle, they will contract and bring about the constriction of the pupil. So this is called direct light or the pupillary reflex. Another type is that if you patient is there which is unconscious, you want to know the status, whether his brain is working or not, same as we have done the corneal reflex. So we will switch off the lights of that room where the patient is lying. We open the eye and we put a torch. We put a light. What we see? That there is a constriction of the pupil. Again it means short ciliary nerves are okay. Ciliary ganglion is okay. Oculomotor nerve is okay. Midbrain is okay. Brain is okay. Same, go back, retro. So we have judged the status of the brain of the patient, unconscious patient. Again we can relieve the relative at least that your patient is okay, his brain is working. No doubt he is unconscious. He met a very severe car accident or roadside accident, but still there is some hope. So you can bring the smile on the faces of the relatives. Without CT scan, this is the anatomy. Who knows the doctor who is standing? If you know the anatomy, he has attended the classes of this cord, then he can do. So that is the anatomy is so depth. So it will help you whole of your life. This simple test you can judge. But what happens if I am checking the another eye where I have not put the light and I open it? What I see? That there is a pupil is also constricted on the opposite side. So such a reflex is called consensual reflex. Consensual light or pupillary reflex. What is the explanation? We have put the light only on the one eye, other is why constricting? It is because when we go to the superior colliculus, to the third cranial nerve nuclei, the Adduction vestibular nucleus. This third cranial nerve supplies the Adduction vestibular nucleus of both the sides. Both the sides, not only one side. That's why other eyes also having constriction of the pupil. So that is the answer of the question. Then the third reflex is accommodation reflex. What is accommodation reflex? That I am seeing the last bench students. Suddenly the front line student is doing some khurafat. Suddenly my concentration goes to the front line. So when I am seeing the last bench, I am seeing the distant vision. My eye is there in the distant vision, which is very broad. My vision of the light or the eye field area is very broad when I see the distant image. But when I see the near vision, suddenly, then my eye converges medially. My medial rectus muscle of the eye, it makes my eyes converging because it is a limited area. Here I am seeing all the students from one end to other. Here I am concentrating only one student who is doing mischief. So my eyeball reflexly move medially. Again reflexly. I am not doing, it is coming automatically. So in the near vision, my eye is moving medially, that is called convergence. That is adduction of the eyeball. And who is abduction? Is done by which muscle? Lateral rectus. And which nerve is supplying the lateral rectus? Abduction. And what is the name of the similar name of the any cranial nerve? Abducent. So abduction, lateral rectus, abducent. So this is how to remember the nerve supply of the 6 ocular muscles. Abducent, lateral rectus, abduction. Don't give the formula that you have been given. What is that? C4O4, what you did. No, no, no. If you utter in front of the examiner this time, you get 0 marks. This is common sense. Lateral rectus, abduction, abducent. Superior oblique is the only muscle which is passing through fibrous pulley, that is trochlea, trochlear nerve. Superior oblique, trochlea, trochlear nerve. All other muscles, keep your eyes closed, oculomotor, 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 oculomotor. That finishes. What is the formula to remember? No. The formula is not required here. A rickshaw puller can also answer the questions with the help of that formula. Use your common sense. Why we named the 12 cranial nerves? There is something meaning is there. Go into the depth of that meaning. Then you can become a good doctor. So, during convergence, medial. So it means our human eye is capable of accommodating me or us to see a distant vision as well as near vision at the same time. That is called, what is the meaning of accommodation reflex? What is the efferent impulses then? During distant vision, what happens? Same, light passing through the cornea. From cornea it passes to the lens. Now human lens is biconvex. During distant vision, the size of the lens becomes longer. Its refractive power changes. Its focal length, you know the physics much better than me, because physics was very notorious subject for me. I only opted medical, that there is no numerical here. Okay? So its refractive hour or something focal length changes. But during near vision, everything is changing. Ciliary muscle is acting now. They are contracting and lens of the eyeball becomes more thicker, more smaller. Its refractive power increases. And the pupil is also constricting a little bit for near vision, so that only that much light enters into the pupil and reaches the center part of the lens so that I can see it. So a drastic changes is coming from a distant vision to see a near vision. And this everything is happening because of the accommodation reflex. And only because of the Edinger-Westphal nucleus, which will bring about the constriction of the pupil as well as the contraction of ciliary muscles to make the lens thick. So that you have to answer under the, what is the accommodation reflex. So it reaches the lens, and in the lens what happens? Ciliary muscle contracts and the lens becomes thick in the near vision. And at the same time, the oculomotor nerve reaching the medial rectus, it contracts and bring about convergence of the eyeball or adduction, what is called the adduction movement of the eye. So it is converging like this. So muscles, they are under the effect of the oculomotor nerve. So same response or impulse which is reaching the lens or ciliary muscle. So image is formed here of the near vision, and the same thing goes like this up to later geniculate body is the same. And from later geniculate body, midbrain, superior colliculus, third cranial nerve, and Edinger-Westphal. This is the same. So when it reaches the third cranial nerve is stimulated, it brings about the medial rotation, adduction of the eye. Same response when reaching the Edinger-Westphal nucleus, again the same pathway. Constriction of the pupil is there, ciliary muscle becomes there. So this same. So things are happening, medial rectus is acting, lens is moving, iris is moving during near vision of the accommodation reflex. You have to explain these three steps. I won't repeat it because already I have explained it. So this is called the accommodation reflex. Another reflex related to the eye is the body eye reflex. What is the body eye reflex? With the movement of the eye, our body responds. And this is under the what is called conjugate movement of the eye. Conjugate movement of the eyes are, now while you are reading a line in the book or the copy, your eyes is moving from left to right. See, your head and neck is also moving with it. You are not moving, this is reflexly. So again it is a reflex. Eye body reflex. So eye body reflex, how you explain? Again, when I see the eye, the written words, same is the retina image of the copy line is formed here and reaches the optic nerve, same optic chiasma tract, lateral geniculate body. And from lateral geniculate body, it goes to the midbrain goes to the superior colliculus, and then to the third cranial nerve nucleus. And the fibers from the superior colliculus go to the third cranial nerve at the same time. Same fibers from the superior colliculus reaches the broad mesh number area 6. Broad mesh number 6. Where it lies, anybody? Area number 6. Functional areas of cerebrum. This is the area. Broad mesh number of precentral gyrus is 4. And what is the number of this small area in front of the precentral gyrus is number 6. What is this called? Frontal eye field area. Remember, frontal, so it is concerned with the eye. And what we have uttered at that time, that this area is responsible for conjugate movements. So here we will explain now with the orbit. So at the same time, the impulse reaches the area number 6 of the precentral gyrus. It ascends upward from midbrain to the crus cerebri, and crus cerebri to the internal capsule to the corona radiata, and corona radiata will reach there. At the same time, when it reaches the conscious level of the brain, now we know that we are reading a book or the copy, written words. Then from here, the fibers that descend from frontal eye field area back to the corona radiata, then internal capsule. Which part of the internal capsule? 3 parts: anterior limb, genu, and posterior limb. Which type of fibers are present in the genu? What the genu contains? Which type of fibers? Is the frontopontine and corticonuclear fibers for only head and neck. So corona radiata also brings about not only corticospinal, it also carries the corticonuclear fibers. And these corticonuclear fibers, what is the definition? When you turn the white matter of the cerebrum, 3 types of the fibers. Projection fibers, again 3 types: corticospinal, corticonuclear, and corticopontine. So out of these 3, this is corticonuclear fibers. Cortico means they start from the cortex or the gray matter of the cerebrum, and other than precentral gyrus. And nuclear means, what is the meaning of word nuclear? Corticonuclear means they end into the motor cranial nerve nuclei. That is the meaning of corticonuclear. Out of 12 cranial nerves, whosoever nerves are motor and whose nuclei are scattered in the brainstem. For example, 3rd and 4th both are trochlear and oculomotor are motor. Their nuclei are situated in the level of midbrain. At the level of the pons, 6th and 7th motor, and 5th, their nuclei are present in the pons. Come down, medulla. There are also motor nuclei of last cranial nerve, hypoglossal. Then vagus, glossopharyngeal, accessory nerve supplying the trapezius and sternocleidomastoid. So these are the scattered cranial nerve, motor nerve nuclei. Some are in the midbrain, some are in the pons, some are. So the descending fibers from the genu of the internal capsule will terminate into the motor cranial nerve nuclei. That's why their name is corticonuclear. Or in the other words, they are under the effect of or they take the guidance from higher center. Which center? Cerebrum. There is nothing above the cerebrum end. So all these cranial nerves, they get the guide from the instructions from the higher center, that is the cerebrum, with the different functional areas. Why we are stressing upon the functional areas? Some are 44, some are 45, 4 number. then 6th number, 9th, 10th, Premji area. So they are scattered areas. So all they will guiding the lower lying cranial nerve nuclei, motor or sensory. So that is the meaning. So they go to the internal capsule of the genu. From genu they go down. From the genu where they will go down? Into the crus cerebri of the midbrain. And from the crus cerebri of the midbrain they go to the medulla to supply the 11th cranial nerve, because it has to supply sternocleidomastoid and trapezius. Who is turning your head right and left? Which muscle? Sternocleido. And what is the nerve supply? Accessory nerve. Plus C2 and C3. If you read the sternocleidomastoid, origin, insertion, action, nerve supply applied, then you will see. Not only the cranial nerve is supplying, plus you have to write C2 and C3 of spinal cord is also supplying the sternocleidomastoid. And trapezius, what is nerve supply? Not only the accessory nerve, plus C3 and C4 also. Why? Because neck is lying at the junction of spinal cord and cranial nerves. So there is a dual nerve supply of the muscles. Cranial nerve is also supplying and spinal cord ventral rami is also supplying. Because ventral rami is from ventral horn of the spinal cord you have done, that is motor, M4M. So these fibers which are going down into cranial nerve nuclei, they will supply the 11th cranial nerve and bring about the movement of the neck as we move towards the response. At the same time, these fibers they further descend down from the medulla to the spinal cord, because they have to supply now C2 and C3 and C3, C4 also. It means they have to go through the cervical plexus, which is formed by from C1, C2, C3 and C4. So they go down to them, and from there they go to the spinal cord. And these fibers from the brain going down to the spinal cord, they are called, from superior colliculus they go down, they are called tectospinal. We have done tectospinal tract in the anterior column of the spinal cord, we have explained it. So tectospinal is there. So tectospinal is the extrapyramidal system. They are also, all descending fibers, they are M4M, they are motor. So they will supply the sternocleidomastoid and trapezius, C2 and C3. So these tectospinal fibers, they are only present in the upper cervical. Upper cervical means upper only up to C4. They are not going up. So that is the response. So they supply the, so because when they go to the spinal cord, this tectospinal, they come out, and this is bringing the movement of the, they are called the conjugate movement. The last reflex is ciliospinal reflex. Ciliospinal reflex. What is this? This is the skin eye reflex. Skin eye reflex. So whenever you wear some new pinch is there. What is new pinch? It's a very painful procedure sometimes if your nails are very sharp. So whenever the skin is pinched painfully, then what happens? The pupil dilates. Pupil dilate as the response of the painful stimulus to the skin of the upper limb or upper part of the body. So what is the reflex arc? What happens? How it reaches the pupil? The explanation is that from the skin, pinch is there, and we know the spinal cord is there, and they reach the posterior horn. All these sensory stimuli from general sensory from the skin, they reach the posterior horn. And from here, in the upper part, in the thoracolumbar region, there is a lateral horn of the gray matter. So this painful stimulus from the skin reaches here. From here they relay and they go to the ventral horn cell. From ventral horn the motor nerve come. Motor nerve will supply the muscles. Now from here, preganglionic parasympathetic fibers, they start from the sympathetic ganglion. Lateral horn is sympathetic functionally, you know. So preganglionic sympathetic fibers, they accompany the motor nerve and they come out. The sympathetic fibers. So they come out of the spinal cord, and these sympathetic fibers, they are thoracolumbar. So in the upper T1 and T2 level, these sympathetic fibers, they form a, you have done the thorax, you know what is thorax? It is a long sympathetic chain, and there are 12 intercostal nerves and 12 ganglion, sympathetic ganglion, and the cervical, there are only 3, middle, inferior and superior. So fibers which are coming from T1 and T2 upper sympathetic ganglion, they accompany the preganglionic parasympathetic fibers, they relay into them, T1 and T2, and from here these postganglion fibers arise which ascend upward, and they reach the superior cervical ganglion, and parallel to the superior cervical ganglion there lies the internal carotid artery. Now internal carotid artery is already having the sympathetic plexus around it, and in the orbit there is only one artery is there to supply all the structures. Which is the artery inside the eye? Is the ophthalmic artery, and ophthalmic artery is the branch of internal carotid artery. So same sympathetic plexus around the internal carotid artery will deliver the fibers on the ophthalmic artery also. And these sympathetic fibers, they are already postganglionic. They will enter into the ciliary ganglion because artery is reaching the eyeball. So sympathetic fibers, they go without any relay. They come out as the short ciliary nerves, and these, they pierce the sclera, pierce the choroid, and where they reach? Radial muscles of the eye, sympathetic, and this will bring about the dilatation of the. So that is the response. That how they reach, you should know the last part is the dissection part of the orbit. So we don't give the dissection of the front of the eye. We go into the anterior cranial fossa. And in the anterior cranial fossa, we know here this is called the orbital plate. What lies below it? Eye. What lies here? Nose. So when we break the roof of the bony orbit here by the chisel and the hammer, the medial wall of the bony orbit is straight, lateral wall is oblique. Here is the optic canal. This is the sulcus chiasmaticus. So when we break the roof of the orbit, what we see immediately below the roof? Liver function test. L, F, T, 3 nerves, L, F and T. Same we make here, L, F and T. Remember the formula, liver function test. L is lateral, lacrimal, frontal and trochlear. So 3 nerves and 3 muscles below them. Here, lateral rectus. In the middle, LPS. Here, superior oblique, and here lies the fibrous pulley here, and eyeball is visible below them with the tortuous optic nerve coming out from optic canal. At the same time, internal carotid artery here, the ophthalmic artery branch enters the optic canal inferolateral and supply the eyeball and muscles. So 3 muscles, 3 nerves, remember. And between the optic nerve and lateral rectus, What lies here? 1 to 2 mm size, pinhead size, ciliary. So you should know where it lies in the orbit. Near the apex, between optic nerve and lateral rectus. So that you have to remember. When you remove this nerve and the muscle, you cut it here. Below you find the optic nerve. And below the optic nerve, which muscle is visible? Inferior rectus. Any nerve which is entering into the lateral rectus, label it as the abducent. Any nerve entering into the superior oblique, trochlear, see the superior oblique reflected medially or laterally. Immediately below, which muscle you find? Medially, medial rectus. When you cut the LPS, immediately below, which muscle you find? Superior rectus. Obvious, superior rectus you will find. So this is how you see the dissection part of the eyeball. And the superior rectus muscle, superior oblique muscle, it goes from here, passing in the trochlea, moves back into the eyeball for insertion. Where is it inserted? Posterior upper outer quadrant. Posterior upper lateral or outer quadrant, because its function is intorsion of the eye. Axis is antero-posterior, intorsion. What is the action of the inferior oblique? Extortion. That you have to remember. So why it is called oblique muscle? Because here it is going straight from the pulley, it turns back, it becomes oblique. That's why we have to name superior oblique. Because immediately below and parallel, which muscle is lying? Medial rectus, which is only straight. Rectus means, in anatomy, rectus means straight. All other are straight muscle. So this is how it is inserted here. So that's all about the dissection. We go step by step and we explore each and everything in the what is called. Lastly, we remove the eyeball, lift it up, and what we see below? Insertion of inferior oblique, which is the only muscle we are taking not from the zin but outside from here, from the lower border of the bony orbit. And here we see the insertion is in the inferior medial lower compartment, because it has to bring the extortion of the eyeball. So that is all about the orbit.